Hello everybody. Today we are going to discuss about management of the variceal bleeding. So gastrointestinal bleeding, variceal hemorrhage occurs because of the rupture of variceal wall due to excessive wall tension. So variceal wall tension is the intrinsic property of the vessel wall that opposes the expansive force determined by the variceal transmural pressure, which depends on the portal pressure and the vessel size. Once variceal wall rupture occurs, the amount of the bleeding is related to the transmural pressure and to the area of rupture in the vessel wall and to the blood viscosity or alteration of the homeostasis. All these factors can be influenced by the therapy. Drug therapy and portosystemic derivative procedures reduces the portal pressure. Endoscopic therapies and the other physical methods such as balloon tamponade and the expandable prosthesis act merely by both interrupting the blood flow into varix and sealing the vascular wall. Portal pressure is the key factor determining both variceal rupture and the severity of the bleeding episode. During acute bleeding, the portal pressure may increase because of the different factors such as overtransfusion or absorption of blood from the gut, which may have role in failure to control bleeding or precipitating rebleeding. So portal pressure is usually assessed by the hepatic venous pressure gradient. Now, what are the recommendations? Because they are deemed high risk, the patient in whom decompensation develop should have gastroscopy performed to screen for gastroesophageal varices unless previously diagnosed and treated. So EGD is performed. If EGD is performed, the present size and the presence of the red well marks should be reported. In patient without varices on screening EGD, in whom the etiological factor persists or the state of decompensation continues, screening EGD should be repeated every year. In the remaining patient, the screening could be prolonged, but the exact interval is unclear and more data is required. Now, prevention and the treatment of variceal bleeding. Primary prophylaxis must be initiated upon detection of the high-risk varices. That is small varices with the red sign, medium and large varices irrespective of child book classification, small varices in the child book C patient and because of the increased risk of variceal hemorrhage. Patient with the small varices with the red well marks or child book C should be treated with non-selective beta blocker. Patient with the median large varices should be treated with either non-selective beta blocker or endoscopic bland ligation. The choice of treatment can be based on the local resources and expertise, patient preference, and contraindication in the adverse event. Non-selective beta blocker could be preferred because in addition to the lowering portal pressure, they also exert the other potential beneficial effect. Although ascites is not a contraindication for non-selective beta blocker, the caution should be exercised in the case of severe and the refractory ascites. High doses of the non-selective beta blocker should be avoided. The use of carvedilol cannot be recommended at present. The patient with the progressive hypotension, that is systolic blood pressure of less than 90 mmHg, or in patient who develop acute intercurrent conditions such as bleeding, sepsis, SBP, or ACAT, non-selective beta blocker should be discontinued. After recovery, the reinstatement of the non-selective beta blocker can be attempted. When non-selective beta blocker intolerance or contraindication persists, the patient bleeding risk should be managed by expeditious endovascular band ligation. Combination therapy of non-selective beta blocker and EBL is recommended since it reduces the risk of rebleeding compared with monotherapy. Similar recommendations for primary prophylaxis can be made with respect to the non-selective beta blocker usage in patients with ascites or developing acute intercurrent condition. If patient continues to be intolerant to non-selective beta blocker, covered tips placement is recommended provided that there are no absolute contraindications. Now about variceal hemorrhage, acute GI bleeding in cirrhosis, either because of gastroesophageal varices or non-variceal lesion, is the medical emergency with high incidence of complication and high mortality. Therefore, requires the intensive care. Acute variceal hemorrhage must be suspected in any cirrhotic patient presented with upper acute GI bleeding, and treatment should be started as soon as bleeding is clinically confirmed, regardless the lack of confirmation by upper endoscopy. Anemia. Vasoactive drug therapy and antibiotic prophylaxis should be initiated as soon as the AVH is suspected. Uh, Goals of therapy in acute variceal hemorrhage include control of bleeding as well as prevention of early recurrence and prevention of 6 weeks mortality, which is considered the main treatment outcome by consensus. Blood volume restitution should be initiated promptly to restore and maintain hemodynamic stability to ensure tissue perfusion and oxygen delivery. To facilitate the resuscitation, at least 2 catheters should be placed, large enough to allow rapid volume expansion, which can usually be done with crystalloid. No benefit has been demonstrated with the use of colloid compared to crystalloid. Red blood cells are used to improve oxygen delivery to tissue in case of severe anemia. Restrictive transfusion strategy is adequate in most patients with acute GI bleeding with hemoglobin threshold for transfusion of 7 gram per dl and the target range after transfusion of 7 to 9 gram per day. The threshold for transfusion may be higher in patients with massive hemorrhage or in those with underlying condition that precludes adequate physiological response to acute anemia. Recommendation regarding management of coagulopathy and thrombocytopenia cannot be made based on the currently available data. As mentioned above, vasoactive drug therapy should be initiated as soon as acute variceal hemorrhage is suspected. Starting vasoactive drugs before endoscopy decreases the incidence of active bleeding during endoscopy and facilitated endoscopic therapy, improving the control of bleeding and potential survival. Either terlipressin, somatostatin, and octreotide are accepted drugs with proven efficacy. All these drugs require IV administration. The recommended dose of terlipressin is 2 mg per 4 hour during first 48 hours, followed by 1 mg every 4 hours thereafter. The recommended dose of somatostatin is continuous infusion of 250 mg per hour can be increased to 500 mg per hour with additional bolus of 250 mg. The recommended dose of octreotide is the continuous infusion of the 50 mg per hour with initial bolus of 50 mg. The bolus somatostatin and octreotide can be given again if bleeding is ongoing. Once acute variceal hemorrhage is confirmed, the vasoactive drug therapy should be administered for 5 days to avoid early bleeding. Shorter administration of vasoactive drug, that is 24 to 48 hours, can be considered in less severe episode, although more data are required. Once blood volume restitution has been initiated and hemodynamic stability has been achieved, the upper endoscopy should be performed as soon as possible within first 12 hours after admission to ascertain the cause of hemorrhage and to provide endoscopic therapy if indicated. Erythromycin should be considered before emergency endoscopy, that is 250 mg IV 30 to 120 minutes before to facilitate procedure by improving visibility and in the absence of contraindications, that is QT prolongation. With acute variceal hemorrhage is confirmed by endoscopy, endoscopic band ligation should be performed within same procedure. EBL is more effective than sclerotherapy to control bleeding with fewer adverse effects and may improve survival. Sclerotherapy can be used when ligation is not feasible. The combination of endoscopic therapy and vasoactive drug is more effective than isolated use of either of these options alone because it combines the local hemostatic effect on varices induced by endoscopic treatment and the portal hypertensive effect achieved with the drug. This combination is currently considered the standard of care in the acute variceal hemorrhage. Then cyanoacrylate injection and the EBL are accepted option for endoscopic therapy in patients bleeding from the gastric varices as both therapies are equally effective. However, EBL should only be performed on small gastric varices in which complete vessel can be suctioned into ligation device. Other endoscopic therapies such as endoscopic ultrasound guided insertion of coil and cyanoacrylate, are available for fundal varices. Prevention of complication should run simultaneous to hemostatic therapy from admission of the patient with cirrhosis and acute GI bleeding. The main complication, whatever the cause of bleeding, include bacterial infection like aspiration pneumonia, spontaneous bacterial peritonitis, hepatic encephalopathy, and deterioration of the renal function. Bacterial infection are observed in more than 50% of patients and may already be present at the time of bleeding, acting as precipitating event. Moreover, the presence of bacterial infection is an independent predictor of failure to control bleeding and death. Antibiotic prophylaxis is recommended because it reduces the incidence of infection and improves control of bleeding and survival. Ceftriaxone, that is 1 gram every 24 hours for up to 7 days, is the first choice in patients with advanced cirrhosis and in those with quinolone prophylaxis and in hospital setting with high prevalence of quinolone resistant bacterial infection. Oral quinolone, that is norfloxacin 400 mg BD, can be used in remaining patients. These recommendations are, however, best evaluated and cross-checked from the perspective of local resistant pattern. Renal function should be preserved by adequate replacement of fluid and the electrolyte. Nephrotoxic drugs like aminoglycoside and NSAID, as well as large volume paracentesis, beta blocker, and vasodilators, and other hypotensive drugs should be avoided during the course of acute variceal hemorrhage. Oral non-absorbable disaccharide may be used to prevent development of hepatic encephalopathy, although more studies are needed. When encephalopathy develops, lactulose or lactic toll should be used. Proton pump inhibitors have not shown efficacy for management of acute variceal hemorrhage. However, a short course of PPI after EBL may reduce the size of post-banding ulcer. Despite therapy with vasoactive drugs plus EBL and prophylactic antibiotic, up to 10 to 15% of patients with acute variceal hemorrhage have persistent bleeding and early rebuilding. In such a cases, TIPS should be considered as a rescue therapy of choice. When TIPS is not feasible or in case of modest rebleeding, a second endoscopic therapy may be attempted when vasoactive drugs can also be optimized by doubling the dose of somatostatin or changing to terlipressin if not used previously. Balloon tamponade should be used in case of massive bleeding as a temporary bridge until definitive treatment can be instituted and for maximum 24 hours, preferably under intensive care facilities. Because of the high risk of aspiration pneumonia, tamponade should be preceded by prophylactic orotracheal intubation in comatose or encephalopathic patients. Removable, covered, and self-expanding esophageal stent are an alternative to balloon tamponade and may have lower rates of serious adverse events. So RCT suggests that high-risk patient, early or preemptive PTFE coated tips placed within 72 hours may result in better permanent control of bleeding and may improve survival. However, these studies had a relevant drawbacks such as inclusion of highly selected population because of strict exclusion criteria, with observational studies have not confirmed the effect on survival. The use of child has also been criticized. It has also been suggested that a recalibrated MELD score may better identify patients at high risk than the other score. At present, early tips should be considered in patients with childhood class C with score of less than 40. However, future studies should clarify which criteria may be preferred to select high-risk patients before wide implementation of early tips. Further studies should also clarify whether adequate stratification of risk in patients with acute variceal hemorrhage can optimize therapy. So recommendations are acute GI bleeding, both due to gastroesophageal varices and non-variceal lesion, carries a high incidence of complication and mortality in decompensated cirrhosis and therefore require close monitoring. Volume replacement should be initiated promptly to restore and maintain hemodynamic stability. Either colloid and crystalloid should be used. Starch should not be used for volume replacement. Restrictive transfusion strategy is recommended in most patients with hemoglobin threshold for transfusion of 7 gram per dl and target range of 7 to 9 gram per day. Antibiotic prophylaxis is recommended in cirrhotic patients with acute GI bleeding because it reduces incidence of infection and improve control of bleeding and survival. Treatment should be initiated on presentation of bleeding and continued up to 7 days. Ceftriaxone 1 gram every 24 hours is the first choice in patients with decompensated cirrhosis, those already on the quinolone prophylaxis, and in hospital setting with the high prevalence of quinolone resistant bacterial infection. Oral quinolone, that is norfloxacin 400 mg BD, should be used in remaining patients. Vasoactive drug therapy should be initiated as soon as acute variceal bleeding is suspected before endoscopy. Terlipressin, somatostatin, octreotide are accepted options. In patients with the acute variceal drug therapy should be administered for 3 to 5 days. Gastroscopy should be performed within first 24 hours after admission once hemodynamic stability has been achieved to ascertain the cause of hemorrhage and to provide endoscopic therapy. When variceal bleeding is confirmed by endoscopy, variceal ligation should be performed within same procedure. In the absence of contraindication, that is QT prolongation, pre-endoscopy erythromycin, that is 250 mg IV, 30 to 120 minutes before, can be used to facilitate the procedure. The combination of vasoactive drug and ligation is recommended as a first therapeutic option in acute variceal bleeding. Early preemptive covered tips, that is placed within 24 to 72 hours, can be suggested in selected high risk patients such as those with child class C with score less than 40. However, criteria for high risk patient, particularly child B with active bleeding, remain debatable and needs further study. Up to 10 to 15% of patients have persistent bleeding or early rebleeding despite treatment with vasoactive drug plus variceal ligation and prophylactic antibiotic. TIP should be used as rescue therapy of choice in such a patient. Balloon tamponade should be used in uncontrolled bleeding but with prerequisite of expertise or as a temporary bridge until definitive treatment can be instituted on for maximum of 24 hours. Removable, covered, and self-expanding esophageal stent can be used as alternative to balloon tamponade. In the context of bleeding, where encephalopathy is commonly encountered, prophylactic lactulose may be used to prevent encephalopathy, but further studies are needed. Beta blocker and vasodilator should be avoided during acute bleeding episode. Now, this is the algorithm for the management of acute GI bleeding. If there is acute GI bleed with portal hypertension, then initial assessment should consist of history, physical examination, and culture. First, we need to manage this airway breathing circulation. Volume for blood loss, we need to replace with crystalloid and then go for the blood transfusion. For blood transfusion, follow restrictive strategy for the transfusion. Follow the HB of 7 gram per dl and target of 7 to 9 gram. Immediate start of drug therapy, that is somatostatin, terlipressin or antibiotic prophylaxis. Early diagnostic, perform early diagnostic endoscopy. If there is a confirmed varices, then go for endoscopic therapy, that is band ligation. Maintain vasoactive drug therapy for 3 to 5 days and antibiotic prophylaxis. If it is controlled, then go for early tips in high risk patient. If further bleeding has occurred, then go for rescue with tips. Now about portal hypertension, gastropathy, and intestinopathy. Non-selective beta blocker and iron supplementation and or blood transfusion, when indicated, are recommended as first-line therapy for chronic hemorrhage from portal hypertension gastropathy. In patient with the transfusion-dependent portal hypertension gastropathy, in whom non-selective beta blocker fail or are not tolerated, covered tips placement may be used, provided the patient has no contraindication for tips. Acute portal hypertension, gastropathy, bleeding may be treated with somatostatin analog or terlipressin, but substantiating data are limited. Thank you, guys.